So we're going to talk here about vitamin D. And vitamin D is really important for the metabolism and the regulation of calcium and phosphate. It's important to have a really good understanding of that regulatory process and physiology, how vitamin D works, not just for understanding what happens when there's vitamin D deficiency, but also for understanding what happens when there's excess parathyroid hormone or not enough parathyroid hormone, which is something that you can see in adults with parathyroid hormone tumors. Or parathyroid tumors. So you really should have a good grasp of this, not just for pediatrics, but for adult medicine as well. Vitamin D deficiency, which we're going to spend most of our time talking about here, is going to be for one of two reasons. Either due to a primary vitamin D deficiency, which is most common and particularly very common in the developing world. Vitamin D does not occur isn't present in foods naturally in most cases. And so you get a lot of your vitamin D from fortified foods, particularly milk and cereals. Milk in the United States is pretty much always fortified with vitamin D. You can also have a secondary vitamin D deficiency, and this is just due to malabsorption, and so diseases of the small bowel, particularly Crohn's, celiac disease, can cause a vitamin D deficiency as well. Hypervitaminosis D is excess vitamin D, and remember, because you can't really get vitamin D very readily, it's very difficult to get hypervitaminosis D. Typically, where we see this is in children who get into mom or dad's vitamin D supplements and start taking them. And then rickets is another really important topic when we think of vitamin D deficiency. Vitamin D deficiency isn't the only cause of rickets, but this is really going to be where your calcium and phosphate physiology is going to be really important. Vitamin D physiology is going to be really important in deducing what the actual cause of rickets is. While vitamin D deficiency is not the only cause of rickets, it's the most common, but there are other causes of rickets. And you're going to be able to deduce this based on not only the history and physical exam and all that stuff, but particularly your labs. So this is the physiology here. It's very complex, but if you look at each step, it kind of makes sense. So you can get vitamin D in one of two ways. You can get vitamin D in your diet, but you can also get vitamin D through exposure to sunlight, and that's through the UVB radiation. It's important to remember that there are two ways that children may be outside but don't get enough UVB exposure. One, they can have if they have more pigmentation in their skin. So if they're African American, for instance, that pigment is going to block that UV radiation from getting to the appropriate cholesterol that is going to be converted into vitamin D. And so because of that, African American children have a higher risk of rickets. I've seen, I think, 3 children in my career that had rickets, and they were all African American. And that's just due not necessarily because they're not eating enough vitamin D, but because they might not be getting as much vitamin D as they need to, based on the fact that they can't produce as much vitamin D as much as their fair, complexed white peers. So then that comes into another way that you can get deficient UV exposure, and that is if you live in a northern climate, like here in Minnesota, for instance, where in the winter and in the fall and early spring, the sun is out, but the sunlight is a little less intense, and so you're not getting the appropriate intensity of UV exposure, and so therefore you don't produce enough vitamin D. So once you have vitamin D in your diet, or either in your diet or through exposure to sunlight, that vitamin D needs to go through a couple steps in order to be converted into its active form. So first it needs to go through the liver, and by going through the liver, it is exposed to an enzyme called 25-hydroxylase, and 25-hydroxylase converts it to 25-hydroxy vitamin D, so it just attaches an alcohol onto vitamin D. After that, it goes through the kidney, and that converts the 25-hydroxy vitamin D into 1,25-dihydroxyvitamin D, or more conveniently just called calcitriol. And calcitriol is the active form of vitamin D. So when you test children for vitamin D deficiency, you want to make sure that you're testing both the precursor to calcitriol as well as the calcitriol itself, because there is a disease where you can have a deficiency of 1-hydroxylase, and so in those children they get enough vitamin D, but they aren't converting it into the active form. Once you have calcitriol produced, that calcitriol is going to encourage bone mineralization. It also increases the uptake of the calcium and phosphate that's been ingested in the diet. It also suppresses the creation of parathyroid hormone. When you don't have enough calcium in your bloodstream, your body is going to regulate this because it's extremely important that you have appropriate calcium. If you have hypocalcemia or hypercalcemia, you can die from both of those if it's severe enough. And so parathyroid hormone is really going to sense that calcium level, and it's going to secrete more or less parathyroid hormone appropriately, presumably if they have a normal parathyroid hormone. So parathyroid hormone, what it does is it increases the absorption of, or increases the production of vitamin D, but it also reduces the amount of vitamin D in the blood because it encourages the excretion of vitamin D. So while vitamin D, it increases the excretion of phosphate. So while vitamin D itself increases the absorption of calcium and phosphate, parathyroid hormone increases the absorption of calcium through vitamin D, but also decreases the serum level of phosphate because it increases the renal excretion. And that's really important when you think of what parathyroid hormone does, and if you have a deficiency or an excess of parathyroid hormone, what that's going to mean in your labs. So really, I would just recommend internalizing this and understanding this process, because it's really going to help you for many different cases when we're talking about bones and calcium and phosphate and parathyroid hormone, etc. So 1,25-dihydroxyvitamin D, or calcitriol, is the biologically active form of vitamin D. Its endogenous production requires two enzymes, and that's 25-hydroxylase and 1-alpha-hydroxylase. Of course, it also requires UV exposure, because you need that in order to make the cholesterol form of vitamin D, or the endogenous form of vitamin D, which is cholecalciferol. So you need both UV exposure and these enzymes. There are certain diseases that affect these enzymes, so that'll be reflected in the labs, and that's why it's important that when you have a child who you suspect has vitamin D deficiency, that you get both of these levels, because if there is a break in this process from converting 25-hydroxyvitamin D into calcitriol, then you understand that, because in those cases you need to replace calcitriol, rather than if they just have a vitamin D deficiency, you can replace that with just regular old vitamin D. At the intestine, calcitriol is going to increase production of calcium binding protein, which allows more calcium to be absorbed through the intestinal mucosa, and that is going to be accompanied by phosphate to maintain electroneutrality. And the net effect of this is going to be to increase serum calcium and increase phosphate, and that's going to allow for bone mineralization. And calcitriol, just as a note, is metabolized by 24-hydroxylase, and that converts calcitriol into calcitriolic acid. The result of that is the inactivation of calcitriol. So that's how we get rid of this calcitriol when we need to. Parathyroid hormone is released by the parathyroids in response to a low serum calcium. And so while parathyroid hormone does increase the production of vitamin D, it doesn't have the exact same effect as vitamin D has itself. So let's talk about why that is. So it upregulates 1-alpha hydroxylase, and that's the enzyme that ultimately will make your calcitriol out of 25-hydroxyvitamin D. And so parathyroid hormone increases the intestinal absorption of calcium and phosphate, but that's just the intestinal absorption. Parathyroid hormone also increases the excretion of phosphate in the urine. And so therefore, the net effect of parathyroid hormone is going to be to increase serum calcium, but it decreases serum phosphate. Even though it increases the absorption of phosphate, it kicks out more phosphate in the kidneys, and so therefore it decreases the serum phosphate. At the bones, it's going to indirectly stimulate the osteoclasts by upregulating a protein called rank ligand. And that rank ligand, when it attaches to rank, I can't remember what that stands for, allows the osteoclasts to mature and then demineralize the bone, and that increases your serum calcium and also phosphate. But the net effect is still to decrease the serum phosphate. So I want you to be able to separate that. Even though there are some effects of parathyroid hormone that are increasing phosphate, because it kicks out more phosphate in the urine than it causes to absorb phosphate elsewhere, the net effect is to decrease serum phosphate. So parathyroid hormone, of course, comes from the parathyroids, and it's stimulated by a low serum calcium, a low serum magnesium, or a high serum phosphate. And that makes sense because what do you want to do if you have a high serum phosphate? You want to kick that out, and parathyroid hormone does just that. It is inhibited by a high serum calcium and an extremely low serum magnesium, as well as low serum phosphate and calcitriol. So again, the net effect of parathyroid hormone is to increase serum calcium, decrease serum phosphate, decrease urinary calcium because we want to preserve calcium if we don't have enough, increase urinary phosphate to excrete it, raise calcitriol levels by converting vitamin D into calcitriol, and then promoting bone demineralization. So this is the chemical process of bone demineralization and mineralization. So you have phosphate and calcium in the serum. Both of those are necessary to get into the bone to make the actual mineral that is part of your bone. So you need both calcium and phosphate. And those are converted to calcium hydroxyapatite by the osteoblasts. So bone demineralization is going to be promoted by parathyroid hormone, low serum calcium, and osteoclast activity. Bone mineralization is promoted by calcitriol, bisphosphonates, which remember is a class of drugs that's given to usually those little old women with osteoporosis. It can also be given in emergency management of hypercalcemia. It's also promoted by osteoblast activity and calcitonin. So hyperphosphatemia is going to be caused by one of two things, either reduced renal phosphate secretion, which is where we see it most commonly in patients with renal failure, and high levels of serum phosphate is a big problem for patients with renal failure and one of the several reasons why they may need to go on to dialysis. We can also see hyperphosphatemia in an increased phosphate load, which is a little less common, but you see it particularly in trauma patients who have experienced cellular injury. So reduced renal phosphate secretion is going to be typically related to kidneys, but you can also see it due to a decrease in parathyroid hormone. Remember, parathyroid hormone is responsible for getting rid of parathyroid hormone out of the kidneys. So if you have low parathyroid hormone, you're going to have higher phosphate levels. Parathyroid suppression, which can be due to vitamin D or vitamin A intoxication, sarcoidosis, or osteolytic metastases, pseudohypoparathyroidism, acromegaly, and heparin toxicity. Increased phosphate load can be due to rapid administration of phosphate, which would be iatrogenic, of course, extensive injury, crush injury, hyperthermia, rhabdomyolysis, very important to remember this, cytotoxic therapy. What we're talking about here is chemotherapy in patients with cancer, fulminant hepatitis, and severe hemolytic anemia. And then, of course, there's transcellular phosphate shifts, metabolic acidosis, or respiratory acidosis can both increase your phosphate levels. Hypophosphatemia can be caused from hyperparathyroidism, malabsorption, respiratory alkalosis, refeeding syndrome. This is one that actually was first discovered when the concentration camps in Nazi Germany were liberated, and they thought, oh, well, look at these poor starving people, and you can see their bones and they're malnourished, and let's just give them a lot of food. And what wound up happening there is their cells were so deprived of ATP from the prolonged starvation that as soon as they got food into their system and nutrients, their cells pulled tons of phosphate in and caused a severe hypophosphatemia, and they wound up dying from that. You can also see this in DKA post-treatment, kind of similar reasons. Tumor, leukemia, lymphoma, because of the phosphate that's being taken in by the cells, liver failure, and then there's congenital causes of hypophosphatemia, which we'll talk about in the rickets section. Primary vitamin D deficiency is the most common cause of rickets globally. There's an increased risk, as we mentioned before, in darker-skinned individuals, those who don't get adequate sun exposure. So particularly here, we're talking about people who live in northern climates, Canada, Sweden, Norway, Russia, up here in the northern part of the United States. Babies who are breastfeeding, there's not so much calcium in breast milk, it's important for babies who are breastfeeding to get supplemental calcium. And then vegans who drink unfortified milk, or vegetarians for that matter. Manifestations of primary vitamin D deficiency are primarily going to be related to hypocalcemia. And so the signs of hypocalcemia, remember, calcium is a stabilizer of cells, especially neurons. And so you can see irritability, jitterness, fatigue, wheezing, muscle cramps, increased DTRs, and seizures. The nervous system is going to be a little hyperactive. And then, of course, rickets in children, osteomalacia in older children and adults. The workup is going to be to get all of these labs that are associated with calcium and phosphate metabolism as well as vitamin D. So you want to get a basic metabolic profile, including calcium, phosphate, and magnesium. You want to get a urine calcium and phosphate. You want to get a 25, that should be 25 hydroxy vitamin D and calcitriol levels. You want to get parathyroid hormone levels, and then you'll also want to get a CBC and radiographs, as well as working up any other possible nutrition deficiency that might be present. The management of primary vitamin D deficiency is pretty simple. You replace the vitamin D, and that's either going to be done by regular vitamin D or calcitriol. You want to make sure that these children are on an adequate diet, and that's going to usually require parent education. You want to replace the calcium if the child is symptomatic. PO is preferred, but if they're real severe symptoms, then you can give IV calcium gluconate. You want to correct magnesium if necessary, and then recheck labs on follow-up. And so the lab results from a primary vitamin D deficiency are going to be, of course, 25 hydroxy vitamin D is going to be low, and calcitriol are low because we're not getting the vitamin D in the diet or through sun exposure. And the result of that is going to be a low serum phosphate because you absorb that with vitamin D. The serum calcium can be variable. Remember that it's very important to get as much regulation of that calcium as possible, because you can die from really low calcium or really high calcium. And so your body's going to regulate that. And it regulates that based on parathyroid hormone. So if you're not getting enough calcium through absorption, your body's going to turn on your parathyroid hormone, and the parathyroid hormone is going to demineralize bone, and that causes both ultimately rickets from vitamin D deficiency, and it also causes bone demineralization. And so your serum calcium can be in the normal range, but it'll probably be in the low normal range. It might be in the high level of the low range, but it's variable. Serum magnesium, that can also be variable, so you want to look at that as well. Secondary vitamin D deficiency can be caused from intestinal malabsorption, so cholestatic liver disease, cystic fibrosis, Crohn's disease, pancreatic insufficiency, celiac disease, really anything that prevents the secretion of bile into the small intestine, anything that prevents the pancreas from secreting the lipases that are necessary for vitamin D absorption, or anything that directly affects the small intestine, like cystic fibrosis, or like Crohn's disease or celiac disease. Severe liver disease, that kind of falls under the vitamin D or under the cholestatic liver disease. But this, remember, if the liver is responsible for that first hydroxylation step in the vitamin D conversion to calcitriol. So if there is severe liver disease, you can also have deficiency of 25-hydroxylase. So that can be another factor. And then increased degradation. So there are medications that can cause the cytochrome system to ramp up. And those medications include phenobarbital, which is given a lot of times for seizures, phenytoin, another thing that's given for seizures, otherwise known as Dilantin, isoniazid and rifampin, those are given for TB. So these all will cause increased degradation of vitamin D, and that's via this cytochrome system. The manifestations of vitamin D deficiency, again, it's going to be just like primary vitamin D deficiency. It's what you really have here is the same problem, but with secondary vitamin D deficiency. You're intaking enough vitamin D, it's just not being absorbed, or it's being degraded. So you'll have symptoms related to hypocalcemia, and then rickets or osteomalacia is another possibility too if it's severe enough. Your workup and management is going to be the same. However, as far as management goes, you're going to address the underlying cause. And so part of your workup, if you suspect, generally based on other symptoms or based on the fact that you think this child is getting enough vitamin D in their diet, but they still have this vitamin D deficiency, you can work the child up for those various causes of malabsorption. So you can get liver profiles, you can get antibodies, anti-endomysial bodies for antibodies for cystic fibrosis or for celiac disease. Sweat chloride test for cystic fibrosis, usually that's done as part of the neonatal screening. Lots of different things you can do to work up a suspected cause of malabsorption. So the management is to give supplements, address the underlying cause. A lot of times if you address and cure the underlying cause, eventually the child won't need vitamin D supplements, but you're going to give that in the short term and then follow up with labs. All right, so hypervitaminosis D is something I've never seen, but it can happen either due to accidental or intentional overconsumption of vitamin D supplements. But it can also be due to if there's accidental over-fortification of vitamin D fortified foods. That's a little less common, but usually where you're going to see hypervitaminosis D is a kid who got into mom and dad's vitamin D supplements, or maybe a teenager or adult who is having Munchausen syndrome or malingering. They can take vitamin D and overdose on that too, or maybe somebody who is just not aware of how much vitamin D they should be taking as a supplement, and they take too much. The manifestations are going to be pretty much everything you see in hypercalcemia. So you're going to get a hypercalcemia here. You'll have polydipsia, polyuria, and dehydration. The neurological signs are going to be associated with the hypercalcemia, and so opposite to hypocalcemia, with hypercalcemia we have a little too much CNS stabilization to the point where it becomes a little hypoactive. So you see lethargy, fatigue, hypotonia. They can be disoriented, they can become psychotic, and ultimately you can get a coma. GI-wise, nausea, vomiting, constipation, you get a little bit of slowing of the GI tract, and so that can cause vomiting. It can also certainly does cause constipation because the intestine is slowed down. Abdominal pain, pancreatitis, the pancreas can become calcified. Cardiac anomalies would be hypertension. You can also get arrhythmias. Again here, calcium is overstabilizing the nerves, and that's going to prolong your QT interval. And then, of course, you have renal issues, because if you're getting too much calcium, you have to excrete that calcium somewhere. That calcium is going to go through the kidneys, and that increases your risk of developing stones. So nephrolithiasis. You can also get calcification of the renal tissue itself. That's nephrocalcinosis, which ultimately can cause acute renal failure, and if it's not treated, will go into chronic renal failure. Your workup is pretty much the exact same thing as for vitamin D deficiency. We're just looking at all the steps and all the things surrounding vitamin D, including all your electrolytes, including in your serum and in your urine. You want to look at the vitamin D levels, both, again, that should say 25-hydroxyvitamin D and calcitriol levels. You want to look at your parathyroid hormone levels, which, of course, are going to be really low. You want to look at EKG just to rule out any cardiac arrhythmia, and then you'll want to get a renal ultrasound to look for stones. Usually those will be symptomatic, but you may see some, and to look for nephrocalcinosis. And usually that's going to be done on these EKG and renal ultrasound will be done on your diagnosis from your lab results. For management, you want to resuscitate them. These patients are typically dehydrated from the polyuria. Once you resuscitate them and they're hydrated, you can then add a loop diuretic, such as furosemide, and that's going to increase the excretion of calcium, which will help you get back to your normal calcium levels. If the patient is really symptomatic and you really need to get the calcium levels down and you can't wait till the patient's hydrated, you can give bisphosphonates. Those activate the osteoblasts, and that's going to get rid of the calcium by mineralizing the bone. And that's like Boniva and those drugs that are marketed for osteoporosis, abandonate, alendronate. Patient and parent education, usually this is an accidental issue, so you want to tell the parent to put up the drugs, put up the supplements. A lot of times parents don't know that vitamins can be dangerous, so that's something to make them aware of. And then you'll want to follow these kids up. Vitamin D is stored in the fat, and so just because you address the acute problem doesn't mean they're completely out of the woods. They can have that vitamin D can persist in the fat for 6 to 9 months, so you'll want to follow them up and treat them accordingly.